Hello and welcome to another episode of Higher Ed Unpacked. I'm George Glover. I'm joined by my co-host Tim. Tim, welcome.
Great to be here, George.
Excited to be joined by the wonderful Professor Rachel Huxley. Rachel, welcome.
Thank you very much. It's a pleasure to be with you this morning.
Now, before we kind of get stuck into learning a bit about you and your role, perhaps for our listeners, I can give a bit of a run sheet through your very impressive background and kind of current roles. So currently the Executive Dean of Faculty of Health at Deakin University, Chair of Victorian Cardiovascular and Research Network, visiting Professor of Epidemiology at the University of Oxford, where I believe you did your PhD as well, Honorary Professor at the George Institute for Global Health at the University of New South Wales. So yeah, great to have you on and very impressive.
Rachel, I think you've got many. I also Google stalked you before we started, and you've got a lot of hats on that. If you're looking at the podcast and you want a little short read, then go on to your website for the Deakin website. The number of hats you're wearing with boards, visiting positions. Is it hard to keep track?
I think so, but the other one I wear is I'm also an Uber driver at night for kids, so that as well. But I actually started my career as a weather girl.
Really?
Sort of. I used to, when I finished my PhD in Oxford, I worked for the meteorological office in Bracknell.
Oh, wow.
And they have the largest supercomputer in the Northern Hemisphere. And this was about 25 years ago, and they're really interested in understanding how the weather impacts on hospital admissions. And there's a very strong correlation between weather patterns, cold, heat, with admissions for cardiovascular disease, for communicable diseases, flu, for fractures when people fall and slip. So part of my role actually was using big data to understand how hospitals can better plan for admissions and load.
Oh, that's fascinating. Yeah. And so do we do the same sort of thing here? Or should we?
We should be doing there. Look, there is some work in that space. I think the piece of work that has been led by some Deakin colleagues actually has been forecasting thunderstorm asthma-induced attacks. So if you remember a few years ago, there was, after some significant crazy weather we had in Melbourne, we had a spate of deaths, unfortunately, due to asthma. And so there is a thunderstorm-induced asthma system that we operate. So so there is, of course, with climate change now, there is a huge understanding and appreciation of the role of the climate and weather patterns on health.
But not so much in America, it would appear, where there's not so much funding for that at the moment.
No, there isn't so much funding for that. You're absolutely right. I think anything to do with climate change is seen with a huge degree of skepticism, unfortunately, in the US. And that's one of the reasons I think we have to step up a little bit more and show more leadership in that space. And I think it's pleasing to see how much more traction research into climate change and the health hazards has had in Australia over the last 10 years, particularly from the NHMRC. So there's some really strong groups in Melbourne, particularly at Monash. Yumin Gu, close friend and colleague, has been leading some fantastic work, as well as at Monash and Deakin ourselves. We're really trying to understand how we can actually provide solutions, not just quantify the impacts, but actually what are some of the solutions that we can help our communities implement to support and navigate through this really difficult time?
I was going to say, because there's so many mixed emotions associated with climate change, and obviously, particularly if you're a young person here in Australia, it's pretty. What's kind of your emotion when you think, because you're obviously on the cold face of the research? Is it one of hope? Is it one of frustration? Is it what's kind of what's your feelings towards how we're kind of running at this, impeding challenge, or what challenge that's here right now?
Well, I think we've turned a corner in that there is much more awareness and advocacy for more to be done in advocating for solutions to address climate change, the prevention of climate change. So it's now getting funded, which 10 years ago, it was seen as more of a sort of a peripheral research interest, but now it's very much in the mainstream.
Yeah.
And I think there is much more acceptance that climate change and changes to how the weather patterns impacts not just on physical health, but mental health. And if you look at surveys of young people in this country, climate change is the biggest concern. It's not jobs, it's not cost of living, it really is the impact of the climate. And I can see that it's feedback we get within our faculty, with our student body, and talking to our own kids. It's something that they're really critically worried about. And
But how do you, as a population health researcher, epidemiologist, how do you flip that from being panic, blind terror, I can't act, won't do anything, the world is going to hell in a handbasket, so I'm not going to worry type of thing.
Yeah.
How do you go flip from that into I can do something? We have got a hope, because there's two sides of that.
Yes, you're absolutely right. And I think it's easy to go down the nihilist route and just think, oh, everything is just beyond my control. You've got big industries pumping out lots of products. But I think bringing it back and understanding what the individual's contribution is. And I think this is where schools have a really fantastic part to play, because a lot of the primary and secondary schools here, they have initiatives to support sustainability. So when you rephrase it into, rather than just all the disaster scenarios around climate, and reframe it in a positive light about how can you as an individual increase your sustainability on a day-to-day basis. And it could be about looking at things as easy as food waste. Can you minimize how much garbage you produce on a daily basis? Make it a fun challenge within your home or your environment. More and more workplaces operating on the sustainable. How many bins do we have now? They used to be so common, and now you'd be hard pressed to find any waste bins in buildings now. Thinking about just day-to-day things like clothing. Where do we source our materials from our clothes? Fast fashion, the impact of cutting down in the amount of fast fashion we purchase. So Australia leads the world, unfortunately, in the amount of clothing we consume.
Yeah.
I mean, it's staggering, but we outpace our American rivals, and that's
crazy.
not a league table I particularly want to top. So thinking about ways in which we can purchase and reuse, recycle. There's a great Peppa Pig, reuse, recycle. What's the other one? There's another one, repurpose or something, material that we use, just to think about what our footprint is in our own individual space. And I think the other thing that is an area I think we're looking at is the carbon footprint associated with food. So when you buy food, do you make a conscious effort to buy food which is sourced locally? Would having the carbon footprint of a particular foodstuff on the labeling, would that impact people's decisions? Similar to how we have the traffic light system and warnings around saturated fat, would that make an impact? And I dare say that if people were aware that their frozen goods came from halfway across the planet, whether that would influence their decision to buy.
Well, can I jump into that? Because you're obviously your primary area of passion and health is health. How do we build health? We've got also issues with, there's going to be sometimes conflicts with, my asparagus is from Mexico or my grapes are from America. But then do you turn people in towards cheaper, non-fresh food options? How do we weigh that as a society that's trying to move towards health?
Oh, that's a good question. And it's really complex as well, because when you look at food availability in Australia, there are gross inequalities in terms of food access and healthy food access in particular. I think we're fortunate living in a metro part of the country that fresh fruit and vegetables and healthy foods are available almost on every street corner. Go 2-3 hours outside of the city, that's not necessarily the case. And thinking about how the families, communities are able to source and afford fresh produce in areas of the country where it's actually grown and then imported into the city. I think there's some really interesting questions and opportunities that need to be addressed there, because if we're to really make any progress in terms of reducing health inequalities in chronic disease across the social divide, food is an obvious contender. We have to start looking at ways in which we make healthy food available at a very affordable price.
And it's one of those challenges, because I mean, I live next door to an orchard, but when I get my apples, apart from flogging them from my brother-in-law, but if I go, but when I get my apples from a supermarket, they're trucked from his orchard to Melbourne to another warehouse and then back to the supermarket. By the time they're there, they're so often bruised, floury, poorly kept, and that the product is almost inedible. And so then it's, well, what else am I buying instead of that apple? But then there's no other options apart from, independent local fruit stores, which do exist, but are sort of struggling. So how do we change? Because you have to have a market intervention to start to affect our health.
Yeah, you're absolutely right. And I think this is where the government needs to have a look at to see what policies can be implemented. Maybe there is an opportunity to say to the big supermarkets that 10% of local
mandate
have to be retained within the local communities at a cost-effective price. Because otherwise I'm not quite sure how we're going to do it. But you're absolutely right. I mean, when you look at the carbon footprint of that apple that's being shipped in and then out again, I mean, it's completely irrational. So I do think this is one area where the government actually does need to weigh in and just make it a mandated part of suppliers, that they have to be able to have retain some of their produce for their local communities.
Do you feel like we're making progress in this area? Because at times it feels, can be sort of information overload. It feels like there's more information coming out about whether it's sustainability, whether it's, in particular about the health of our society. Does it feel like we are making progress, or there's more challenges every day?
I think the biggest challenge actually is the amount of misinformation that's out there. Everybody seemed, it's interesting, during the COVID, everybody seemed to become an epidemiologist. Nobody knew what one was before 2019, and then suddenly everybody knew one. So I do see that how do we manage misinformation, and how do we ensure that what we're receiving in our feeds is reliable and robust and trustworthy? I think that is a huge question that nobody really has any answers to right now, but I see that as a definite challenge for the future, and we really need to try and get our heads together across the divide between the AI engineers and experts with the content experts. So I think there's an opportunity there. I think I'm optimistic. More and more people are aware of healthy behaviors and what's needed for healthy lifestyle. Although saying that, I do see that the health literacy rates amongst some areas of the community are still pretty low. So particularly among the most disadvantaged groups, culturally and linguistically diverse populations and communities. So there needs to be much more of a tailored approach in terms of how we deliver messaging to groups, and much more of a co-design process, because messaging which works, which is effective in one part of the population, may not necessarily be the same for other groups. So I think there's managing the misinformation and then ensuring that the messages that we are communicated are tailored for particular audiences is something else that we need to work on. We can't have a
So was COVID a boom for epidemiology? Has that sustained in terms of the study of and recruiting more?
Well, look, that's a good question. We hoped that we might see a sudden influx in students wanting to become the next generation epidemiologists. hasn't really translated in that way. It's interesting when you look at TV programs, for example, which were focused on forensic pathology or criminology. We definitely saw an uptick in courses which specialized in those particular
absolutely.
areas.
CSI and then
Correct.
forensic science.
Maybe that's what we need. Maybe we need to have a TV program which is
We need some good
dedicated.
directors.
But we're fortunate at Deakin because Catherine Bennett, who was the voice of COVID, is one of our professors within our School of Health and Social Development, and she really was on the essentially the front page on almost every day, pushing the very coherent and clear arguments around.
Is she resting now?
No, Catherine never rests. But no, she's working there's a lot of work happening with the CDC and the inquiry report.
I'm sure. But I suppose it's a slightly facetious question, but also like it would take a lot out of you being the public face during COVID. Is that one of the challenges as an epidemiologist? You have a very public profile for a time, and then while everyone's healthy, no one cares?
I think epidemiology is an interesting field because it's there's a sort of it's split down the middle, and it's defined by in terms of diseases you can catch and those you can't catch. And I'm in the diseases you can't catch.
Right. Yeah.
So that's primarily cardiovascular disease and cancer and the
which
like.
are the ones that are actually killing us more than the ones you can catch.
Correct. But the ones that we can catch tend to receive much more focus because they're thankfully more transient, and we get spikes and peaks. And there's also a lot more fear around them. Whereas
we don't fear getting fat, basically.
Well, it's not so much getting fat, but we cardiovascular disease, if I just take something I know a little bit about, a lot of the risk factors we can't see. So things like blood pressure, cholesterol, your glucose, you can't see. If I were to ask you, do you know your numbers?
Don't ask.
Don't ask. Okay. Classic response, right? So there is, and this goes back to the sort of health literacy issue. Really, the best thing anybody can do in terms of safeguarding their health for the next few years is to actually go and to your GP and have your blood pressure measured, have your cholesterol and your lipids measured, have your blood glucose measured, right? 3 really simple, easy things. But those understanding your risk factor levels now will have a massive impact on your future risk of having a heart attack or stroke or dementia later on in life.
One thing that fascinates me is that someone who is, spent their life working on this area, does that change your choices when you go to the supermarket? I'm an impulse buyer. I like, if it's shiny and on special, I'm like, oh, maybe I'll buy that and eat it. But I probably shouldn't necessarily. How does it affect you personally?
That is such a big question. So I obviously try and live by my words and the advice. But it's really hard. I'm not an angel. And yes, I succumb to temptation. I probably eat far too much salt, for example. I'm a huge salt fan.
Yeah.
Salt or sweet?
Yeah.
I'm not really so much a sweet fan, but salt, the salty nuts, the olives.
Yeah.
And having kids as well, I hate to say it. Yes, I was at McDonald's yesterday buying something because I'm time poor, like a lot of parents, right? So maybe you want to edit that bit out. But for me,
but that's the reality, isn't it? That's the life we're all living. It's not that we're expected, or we or anyone else would expect you to be an angel of eating. It's more,
moderation.
What's the practical thing that hits you? Yeah. Can we start out? Tell what got you started on this whole journey? Why do you actually care about public health?
I was actually thinking about that question before I came into the office, and I think I'll be very honest with you. So I came from quite a disadvantaged background, and my mother, I lost my brother 2 years ago to a heart attack. He had a massive heart attack. He was only 60.
Right.
And it was because my brother has had one of the most common forms of genetic lipid abnormalities in the population. And it's a condition called familial hypercholesterolemia. A bit of a mouthful, FH for short. And it's inherited, being genetic. And my brother inherited it from my mother, who was undiagnosed because, as I mentioned before, lipids are silent. You don't know whether you've got high cholesterol. My mother had obvious telltale signs for FH. She had what were called, underneath her eyes, she had yellow bags of fat deposits. My mother brushed this off. She never saw a GP, couldn't afford it, never saw a GP. She went undetected, even though she lived to the ripe old age of 80. She went undetected and passed on, unfortunately, the mutation to half of my siblings. And my brother was only diagnosed with FH 10 years ago. And the reason he was diagnosed wasn't because he went to the doctors to have his cholesterol measured. It was because my niece, his daughter, went to get treatment for acne. And in order to have an acne prescription for this particular drug, you have to have your lipids tested because it can cause lipid abnormalities. So her lipids at the age of 16 came back sky high. And so they worked back up that it was obviously a genetic condition. And that was when my brother was diagnosed. But what it meant for my brother is that he'd been living with very high levels of cholesterol for 50 of his 60 years. Wow. And by that time, you've done too much damage. And so he succumbed to it. And so for me, it's a very personal thing and this is why I think go and get your risk factors measured, right, before it's too late. Because a lot of the damage happens before.
What is the test? Like, how do you actually?
You just have your blood taken.
Yeah, the blood.
Right? So you just, for blood pressure, for example, actually for all risk factors that we have, so I've mentioned blood pressure and lipids and blood glucose, a lot of the damage happens before you receive a diagnosis of hypertension or you have type 2 diabetes. Those are basically just points in the sand, they're demarcation around when you start getting treatment. But many, many people live in what's called a sort of suboptimal state of blood pressure. So the normal blood pressure is around, what's classified normal is around 120 over 80. That's textbook average, right? But there are many, many more people in this country who live in the condition where they have their blood pressure somewhere between 120 and 140, the top level. Based on that, they would not be classified as hypertensive, right? And so they wouldn't automatically be prescribed a blood pressure lowering drug. However, and this is coming back to the epidemiology, the beauty of the epidemiology is you're looking at populations. Because, say, 90% of the population would live in this sort of bracket of between 120 and 140 blood pressure, the vast number of heart attacks and strokes will happen in this group simply because of the volume of people in that. It's not in those individuals who have blood pressure of above 140. It's a smaller segment of the population.
Right, yeah.
But it's just sheer numbers.
Numbers, yeah, no, absolutely.
So, I mean, the reason I was drawn to epidemiology in the first place back in Oxford is I loved medicine and I really enjoyed maths. And I really did not like hospitals. Seriously, I really don't like going into hospitals. And I avoid them like the plague, pardon the pun. And I could never see myself as a practicing clinician. I really preferred playing with numbers because numbers don't lie. That's the beauty of numbers. Regardless of the language you're speaking, they don't lie.
So you grew up in Germany. You're obviously smart. You
clearly.
Well, did your parents go to uni?
my father went to uni. So I'm the youngest of 7. And my father grew up both my parents grew up in the 1930s from very working class backgrounds. My father won a scholarship to his school, and then he won a scholarship to Manchester University. And then after he graduated from university in the 50s, the choices were, I kid you not, the army or the church.
Right.
And my father, although he was a devout Catholic, the church was not a life for him. So he went into the army, and he spent the first decade or so of his career in Kenya and in other parts of sub-Saharan Africa. And so he went to university, and he always instilled in us children that education is the one thing people can't take away from you, although sadly dementia can. So having an education was the primary goal. And I think education was definitely the way out for me. So where I grew up in Stoke-on-Trent. Now, Stoke-on-Trent is famous for a few things: the pottery industry. So Royal Dalton, that was where coal mining. Okay, so Arthur Scargill and the miners' strikes and Maggie Thatcher. That's just 2. And number 3, it also has the county in the country that has the highest rate of obesity, overweight and obesity,
right,
and cigarette smoking. And when I was growing up in my late teens there, it also had very high rates of teenage pregnancy, which were used as it's so you can tell, you can see.
And which part of that wasn't attractive?
The weather.
So it's the escape. You've clearly got the motivation to go and study like a.
And I got into Oxford, so that was a sort of a watershed moment when doing the exam, the Oxford exam, which is always such it was such an interesting.
Did you automatically become favourite child at that point?
Oh, no. The other 6 siblings would have torn strips off. No way.
And so you're going from that to Oxford. Was it the classic sort of TV style, I've gone from this pottery industry and village of strangeness to another level of strangeness?
Society, yeah.
It was a little strange. So when I went up for the interview, which happened a week before Christmas, I went up to read biology, and my interview was scheduled for a Sunday evening in the University Museum in Oxford. Now, the University's museum is famous because that's where, apart from having some amazing dinosaur exhibits and the like, it's where Charles Darwin's bulldog, Thomas Henry Huxley, argued against the Bishop of Oxford. So the Bishop of Oxford was saying creationism is, that was how the earth came into being. And Thomas Huxley was the one of the key proponents working with Darwin at the time, who was arguing against the Bishop of Oxford at the time. And so when I went up to Oxford to read for biology, I was interviewed by 3 evolutionary biologists. And after the end of the hour interview, similar to this interview process here, I got up and I said, at the time I said, look, I'm not so sure I'm much of a believer in the theory of evolution. Actually, I'm more of a creationist myself. And to say their jaws dropped. I can still hear it, actually.
I'm glad you had the nerve to do that.
And I think they either thought this girl is either incredibly stupid or very, very bright, because there are some significant flaws in the Darwinian theory of evolution around the timing and things. But at the time, I had a very strong faith, less so now. But and so I think they thought the Huxley name was carrying on. I thought, blasphemy, how you could say that. So anyway, I got in, but I have to say, I didn't particularly enjoy my undergraduate years because I did feel very much like a fish out of water. Right. But I absolutely adored the PhD because that was when you get to
Do something interesting.
Yeah.
Study
and
what
something
you love.
for the first time, something that was nobody else has done before. So that's being able to really just pursue your own particular passion and research interest. That was really, so I was very fortunate to have that opportunity.
And then that led into the weather.
And then that led into the weather because I needed some money, and I was trying to figure out what to do next. And I had lined up a postdoc at Cambridge, but I thought on some recommendations, go to Australia for a few months, go and just see what is outside of Oxford, because you've been there for 9 years. The world's a bigger place beyond this sort of very small town. I'm like, yeah, sure. So I came over to Sydney and really enjoyed it. But
What did you enjoy? What was the difference?
The weather would be a big
Yes.
start. The fact that there was no. I enjoyed the lack of hierarchy.
Yeah.
Oxford, despite its progress and reforms, and I'd still find the UK society still very much of a class-based society. Even now, when I go back, I still feel like the working class kid from Stoke-on-Trent, and your options. I really still felt that ceiling. Coming to Australia, I just looked up and there was no ceiling. It was amazing. You can really do whatever it is that was the feeling I had back then, and still the feeling I have now. Regardless of your background, where you come from, Australia is still the place that gives everybody the same opportunity. Well,
and so how does that affect you? So then jumping forward to your current role, heading up the third or fourth largest health faculty in the country, how does that shape the way you create culture?
It's a very good question, because I think my style in particular, I've been very fortunate over the last 6 years in that my leadership team across the faculty, we've got, if I think about the size of the Faculty of Health, more than 18,000 students.
Wow.
Enrolled.
That's bigger than some universities.
Bigger than some universities.
Yep.
So across 5 different schools. So the School of Medicine, Nursing, Psychology, ENS, Exercise and Sports Science, and Health and Social Development, and 3 research institutes. So combined, we have a staff about, a couple of thousand staff. And so I have a leadership team from across the faculty, and we've worked together by and large for about 6 years now. And so I really see
That's
them.
quite unusual.
It's very unusual.
Yeah.
We've had a very stable, and as I said, I have been really blessed by that. I think they might differ, but I would count everyone on that the executive team as friends and colleagues, and we all share a similar vision in terms of where we want to go and how we want to progress the Faculty of Health. And it's that cohesion, it's the true collaboration that we have. It's not a top-down leadership. That's just not my style. It's very much more of a organogram. It's I'm accountable and responsible for the performance of the health faculty, but it's done in partnership with the other leaders.
So that leads into AI and how you're dealing with it, because it's the giant, giant in the room, isn't it? Really, it's where do you start? Because as you said, accountability is key. Everyone wants to know that the basics are being done, but there's so much else going on.
Yeah, I think when AI started rearing its head a couple of years ago, our Deputy Vice Chancellor academic at the time, Liz Johnson, in collaboration with our VC and Martin, said, like, okay, we have to embrace it, right? We can't stick it back in the box. It's not going to go away. And if we're thinking about it, the future, the jobs of the future, they may not necessarily all go to AI, but they'll go to people who can use
Leverage it.
AI,
Yeah, for sure.
right? So we have our responsibility is to equip our students with the ability and wherewithal, as well as with the ethical judgment about when to use AI and when not to use AI. So we try now and embed AI into all of our assessments across the health faculty. Give you an example, systematic reviews. And AI, you plug in, do me a review of, the impact of fast food on cancer. It will do a pretty good job at bringing all the evidence together, right? We then task the student to actually critique it,
Right.
improve upon it, contextualize it to Australia. So they use the AI output as a
Starting
basis,
point. Yeah.
but they're expected to refine, finesse, update, correct where appropriate. But importantly, always have that sort of mindset that this is AI. So just be
Cautious. Yeah.
cautious about where it's sourcing its information from.
And how do you review and how do you take that information and assess where the student's at? And how is that evolving? And you talk about that senior leadership team.
Yeah,
I'm assuming that is changing and evolving to adapt to the technology. Is how do you assess whether a student is making the progress they need to fulfill the kind of requirement for at the end of their studies?
Well, that's a good question. I think it's it will differ by subject area. So because in health, a lot of our learning and assessment is basically done on is, I would say, almost free from AI. It's done on placements. It's competency-based, skills-based assessment, observation of student performance over the length of their course. Yes, of course, in some of the units, it will be easy to utilize AI and things, but that's where we build in more of the sort of the refining context and the like for when students are asked to produce written material on particular things. But because of the nature of the learning within many of the health disciplines, that's something that can't be faked.
Yeah.
So I'm not saying, I mean, for other disciplines across,
For sure,
it's going to be very different. But I think it's fair to say that we're at the very beginning of what is going to be an exciting journey. I think we can't be scared of AI. I think we need to embrace it, but with guardrails around it.
And the potential for health. I mean, that's kind of where everyone's talking about. Probably the most significant application for AI is in identifying and understanding humans and diseases and how how our bodies interact with things to form diseases or not. So it's really pleasing to hear where you're at in terms of how you guys are thinking about it. You're running at it. Do you think that's commonplace here in Australia? Do you think most of your counterparts across other universities have the same view in terms of like, hey, we've got to run at this and we've got to be thinking about how we're leveraging it to get a better outcome for society rather than, to your point, put it in a box and kind of just ignorance for until they no longer can?
I think, I would be surprised if there are any organizations, tertiary education institutions who are not taking this seriously. We're all thinking about how do we do this. I don't think there are any clear runners in the Australian tertiary education sector in terms of who's leading the way. We're all trying to make this up as we go along at the moment. And I think our accrediting bodies, TEXA, for example, they're just sort of sitting back a little bit and watching what we're doing. So we are investing in supporting our educators in how do they use AI, because I think there are some opportunities in terms of using AI to free up to do the low value, time consuming jobs freeing up educators to actually focus on curriculum design and assessments and the like. So I think there are some opportunities there. They're not going to be overnight, obviously. Look, I do see, I think the ethical challenges to AI, that's the sort of the bleeding edge to me, because the technology always outpaces the ethics. And we saw this like a decade ago, or 2 decades ago, I'm showing my age now, around the genetic engineering and genetic testing. Okay. And, you know, I think there are some interesting questions around, we go back to, say, 20 years ago, where genetic tests could identify whether you're at risk of, when you're in your 30s or 40s, whether you're at risk of early onset dementia in later life or dementia later in life. What do you do with that information? Because we don't have any treatments to prevent dementia, right? So
just set the clock running, and how long have I got, essentially?
And so, and I do see the same with, I think of the same with AI around. We have to be really careful that we're not going to make individuals unduly paranoid or panicky about their health. I deliberately don't wear any of the health bots or apps or anything like that. No, because I think there is a temptation that otherwise we become completely
slave to it, to the
data. A slave to the data without really understanding. So how do we use AI? How do we master it? How do we make it a tool for us? And it's going to be a tool in many of the sort of the toolbox for clinicians, rather than be a slave to it. And I think the health industry on the other side, they're all grappling too with how to use AI. You know, I think about the health services across the state, and many of them are still trying to implement electronic records, right?
True.
But that in your job day to day, do you find do you find a use for AI, or do you think, I wish I could automate this process? I mean, we must be leading to less meetings and more useful time and better use of process.
I guess I'm a Luddite still. I still prefer the face-to-face meetings. Sometimes I'll use AI to help write certain things, but a lot of the work I do is much more about the personal interaction and thinking about what are the new careers. So thinking about how do we do. One of the questions I'm trying to think about now is thinking about workforce planning, the health workforce, because that is a significant challenge for Australia, Victoria, for everywhere else in most countries across the globe. And how do we ensure that we have a highly trained, highly skilled workforce for the future without poaching from countries,
from other countries? But is that also an issue? Because you've talked about if only we get if only we can get our basic health results quickly, that would be great. Should we be actually getting a whole lot of machines to do some of this work in health? And what does that mean for the health workforce?
I think potentially. I'm not going to, I take a cautious approach. Where I see a real opportunity for AI in health, from my background as a clinical trialist or with a strong interest in clinical trials, imagining if all the health systems had EMRs, right?
What's an EMR?
So electronic medical record. Right, so when you're admitted,
great,
all your details are part of a record system, an online record system, which could be set up in a way which could alert whether you would be eligible for a particular clinical trial that's running in, say, the US or Canada, right? Having that ability instantaneously to understand whether your patients are eligible for trials that are being run around the globe, that would be a real game changer, because that is a huge, because when you're trying to recruit into a clinical trial, that's a huge time and financial element, 2-3 years often to recruit sufficient number of patients into clinical trials. If we can automate that to globally bring people from all parts of the globe into a network of clinical, I mean, that would be just transformative, I think.
What about the concept that AI, there's this great opportunity for research translation. Most people don't read publications in scientific journals.
Yep.
AI could translate it into plain language. What are the obviously there are risks there. What are your thoughts?
Oh, look, I think this is I think we use this pretty well at the moment because you're right. We're all time poor, and the volume of journals now, we just have to be careful where the material is coming from, right? So we're all aware of predatory journals, for example, but obviously the bona fide tier one journals, being able to summarize in real time the main papers that come out, for somebody like me, that would be amazing. And I also think for policymakers, because research translation is about trying to implement change, trying to influence policy and guidelines and action on the ground. And the way you do that is being able to take a really complex idea often and simplify it, and then underneath it you put, well, what are the potential actions that could come from this? So that's one of the things that we're trying to do more and more in our at Deakin. It's about how do we do the elevator pitch. Often academics haven't been particularly good at being able to communicate their research to the general public, right? We need to do better at that. And one way is if AI can assist you with that. They can come up with a generic summary, which you can just sort of tweak and think, no, just
and then you
nudge
can make
it a
an
bit.
AI avatar to read it to someone, and you don't have to touch it. So.
I think so. I do feel that there are some clear wins, clear benefits. But always being aware of you're going to still need to have oversight, academic or clinical oversight, similar to the technologies that are being developed to help with prognosis of cancers, identifying tumors. In some areas, the machine learning is almost as good or has surpassed that of a trained professional. But you're still going to have clinical judgment. You're still going to have to be able to communicate. I think communication is critical in health services. And if I just digress a little bit, one of the a lot of health services will have what are called COWs, computers on wheels, right? So they'll wheel a computer into the ward, and they'll talk to the patient, and they'll type in all the information, but the computer will be here and the patient will be behind. You don't actually make eye contact with it. Right? What is the impact on the relationship between the clinician and the patient by having this?
Giant.
Absolutely.
And similarly, electronic scribes. Have you heard about the? So when clinicians take notes from, there are some companies now which have what are called physician scribes, where they take notes. You're still going to have to review them and tweak them. But I also think we also have to be cognizant of unintended consequences of new technologies. So thinking about the scribes. Taking notes is a fundamental part of medical students' learning. They learn by taking notes and having the overseeing clinician, go through them. If you have an electronic scribe doing all that now, you're missing a part of that learning.
The storage of information.
The storage and what's pertinent, what's important, what am I missing? So I think those are going to be some of the challenges that we're going to have to think about, the unintended consequences of implementing something. But I think we're sort of, I think most people are open to it.
So looking at the landscape of you want to build the health workforce, you want to work out, where are my students going with AI? You've also got this broader landscape of the Accord.
Oh, yes.
And now this ties in very closely to your personal story. We want to get underrepresented students, from Indigenous people with disabilities, low SES and regional. We want to get them in. They're not always going to feel like they fit when they turn up. Just the same type of experience, or throughout the process. And maybe we're not ready to help them be fit. How do you work towards that as a dean?
Oh, that's an excellent question. So, the University Accord, I applaud the intent to increase student participation. I think up to 80% of the adult workforce by 2050 to have undergone to experience a university higher education as part of their learning journey. The devil is always in the detail, right? So why do we have low representation from socioeconomic disadvantaged groups, from cold groups, first in family? What are the reasons behind that? Within Deakin's footprint, because we have we service the communities in Western Victoria and the Southwest region predominantly. We do have very high rates of under-participation. I see a real opportunity, particularly for Deakin, in terms of thinking about how do we bring more of those students onto campus. And I think partly it's around cost of living, obviously. Many of these students don't have the financial reserves, or their families don't have the financial reserves to support students to undertake a lengthy degree. The placements that the government is offering for implementing come July 1st for nursing and social work will go some way to assisting. But I've got a lot of allied health disciplines who would also benefit enormously from prac placements, psychology, occupation. The list is endless, right? So I think there is scope to think about how do we expand that practical placement scheme. We are fortunate through a large philanthropic bequest from the Drapac family to have established the Damien Drapac Health Equity Centre at Deakin, which was to encourage and support students from a diverse range of backgrounds into medicine. We have the third medical school in Deakin. It's only 15 years old, right? So it's a baby. But we pride ourselves on supporting the communities, providing the health workforce for our regional and rural communities in particular. And what we're trying to do is trying to recruit students who are representative of the communities that they're serving. Right? And to do that, you have to reach into those communities. The second part of that, and this is coming back to the COVID story, is that we need to keep students local. Right? It's no good
coming and going.
Taking them out.
Taking them out of their rural community and bringing them into Metro Melbourne.
Yeah. And so how do you do that? Do you teach into or?
So during COVID, when we had the 5K bubble, we had to think creatively about how we were going to deliver medical education. We have a 4-year MD program. The first 2 years would be done at the local clinical school. So we had one at Warrnambool in Geelong, and then the final 2 years they'd be brought into Metro. Okay. During COVID, we're able to keep the students local and to train within their communities locally. And we found that actually the students had a much better learning experience, because they were one of two rather than one of 200.
Yeah, absolutely.
So late last year, we launched our end-to-end program, the whole 4-year program at 4 sites. Geelong, Ararat, Ballarat and Warrnambool.
Fantastic.
So students can come, study medicine, stay local for the entire length of the course. And we're hoping that this is going to increase the likelihood of these students staying within their community.
Yeah,
because they're often mature age
them there to stay there, but And can you then take that model and do a similar thing with nursing or psychology? Or
So within the Warrnambool precinct, we've just invested about $6 million in establishing the health education precinct at Warrnambool, where we have nursing and public health and social work and psychology, and now with medicine. So we're actually
Fantastic.
had
So
made
you are
a,
actually doing it.
Absolutely, yeah, we're actually doing it, and partnering with our communities to do so. And so we're absolutely committed to extending into our regional and rural footprint to support these communities. I think we have a particular big challenge right now with the new Melton Hospital coming up in 29. So this is under with Western Health, brand new hospital. Right now, haven't got much of an idea how we're going to resource that in terms of staffing it. It reminds me of, this will show my British roots, but there's a brilliant episode of a classic TV series called Yes, Minister.
Right.
The award-winning hospital with no patients.
Yes,
okay,
yes,
well, that could be what we're looking at. So, and the issue for us is that they are going to require up to 4,000 additional health professionals.
Wow.
Right? How do we partner with Western Health to deliver those?
Yeah.
So I think what's got to happen, and we don't currently have this sort of mechanism in place yet, is universities, education providers and health services, the government, they need to come together and figure out a way in which we can actually break down this particular...
Assess demand and actually,
So if you do this area, if you focus on nursing, we'll work on physio, or we'll do da-da-da-da-da. But at the moment, every university is just trying to
do their own thing.
Do their own thing, and I think we need to start thinking a little bit more in a sort of consortium-like model in terms of supporting workforce. And I think, again, coming back to the AI place, one of the challenges we have is around placements, right? Students undertaking all of the clinical disciplines need to spend time in the health service to fulfill their mandatory requirements. We're trying to increase the number of students from low SES backgrounds and other groups to come in line with the Accord to come and undertake these courses. Where do we actually put them in terms of placements? Because we can't create a hospital overnight. It's an incredibly competitive area. But if we are able to use AI and simulations more in the training, cutting back on the mandatory placement hours,
that's interesting.
That might be a model. But then you need to bring in the accrediting agencies and get them. So it's a huge...
Do you then have to go to the public as well and say, it's okay that your doctor's trained in AI to do your stitching? They'll still know what to do.
They'll still know what to do. Well, it's probably better than see one, do one, learn one.
Oh, absolutely.
But we train a lot of other careers. Our defence personnel.
Oh, no. I think it's
we should be
incredibly valid.
I
just think there's probably a bit of a public a threshold to breach in terms of building confidence.
But I don't know about you, but I'd never want to be the first one.
No. You're talking about clinical trials, I mean. I think that's about all we've got time for. It's been a fascinating conversation, Rachel. So thank you so much. We touched on a whole bunch of different topics and really insightful to hear about how this is going to play out in terms of the future. Obviously, lots of challenges, but I guess you mentioned optimistic. I'm certainly optimistic sitting here, hearing you talk about how some of the work you're doing within the university and how you guys are attacking some of the challenges, we're facing as a society. So thank you so much for joining us on Higher Ed Unpacked, and thank you, Tim.
Yeah, thanks. It's been awesome. I likewise felt really optimistic about the future of health. I might go back to my GP after all.
Yeah. Excellent. Good. Well, thanks for having me. I've really enjoyed it.
Thanks very much.